lice away at the bone. So I have a question for you. If they're lysing away at the bone, these malignant tumors, what mineral do you think would be found in excess in the blood if you were supposed to be testing for any mineral in excess in the blood? Calcium, exactly, guys, right? These patients will suffer from hypercalcemia. So the Bence-Jones proteins that are made are the malignant plasma cells, light chain antibody fragments. They're accumulating in the blood, they're accumulating in the urine, and they really help to confirm the diagnosis, right? So, and when they accumulate in the kidneys, they damage the kidneys, okay? And another thing is that these antibodies, they're non-functional. So what does that tell you? They don't serve any purpose for your immune system. So the patients tend to be immunodeficient as a result of that. And because of these malignant tumors forming in the bone and eating away at the bone, pain is a predominant symptom. These patients tend to be in a lot of pain. Now, the median age for multiple myeloma would be males about 70 years old on average. So you don't normally see this disease in children. And the prognosis is not very good because at 70 or 80 years old, you're really not trying to give this elderly man aggressive combination of chemo and radiation. You know, that's not how you want to spend the last few years of your life, right? So typically multiple myeloma does not have a very good prognosis, especially because it's so aggressive and it forms these multiple sites. So it ends up in our chapter because you get these pathologic fractures, which are very, very common. The bone becomes very destroyed. And then of course, like you guys told me just now, you release calcium into the bloodstream. The patient starts suffering from hypercalcemia, and that it has effects on the nervous system and the musculoskeletal system because of the increase in the calcium. So the they're right here, the Bence-Jones proteins, Shannon, so B cells or B lymphocytes mature into plasma cells, which make antibodies. The Bence-Jones proteins are just antibodies. They're antibodies made by these malignant B cells. So they're basically antibodies. Well, they're actually fragments of antibodies, but essentially they're antibodies made by the malignant cells. So instead of good antibodies to help fight disease and bacteria and viruses, it ends up being, very good. Okay, so in terms of our soft tissue injuries, I don't want you guys to go into deep detail, but I do need you to, look at the differences between a ligament injury and a tendon injury. So typically, when we're talking about ligament injuries, we're talking about injuries that are occurring because there is a lot of load on the ligament that exceeds the range of motion for that joint. And as a result, it tears. So the ligament injuries are usually classified by the extent of the tear. Is it mild? Is it moderate? Is it severe? There's a lot of swelling involved, a lot of pain involved, and the treatment is really dependent on the degree of the tear itself, right? Does it surgically need restoration, especially if it's severe, or will it heal on its own if you immobilize the area? All right, compared to a tendon injury, which of course can be from mild to a complete tear of the tendon, but essentially that you normally have this tendon injury as a direct injury to the tendon because of the repetitive motion that you're using that particular area of the body, right? Because the tendon is attaching the muscle to the bone. So you get that inflammation of the tendon because usually from like a lot of movement and motion on that tendon that stresses the tendon itself. So whenever the fibers can't tolerate the stress, it becomes inflamed, and that's typically how you end up with tendon injuries. You may have an infection leading to a tendonitis, but most of the time it's coming from some kind of direct injury or injury from like repetitive motion of using the tendon and stressing the tendon out. Okay. So wrapping up this particular chapter would be the diseases of skeletal muscle. So that would be the ones we're going to do: Duchenne's muscular dystrophy and myasthenia gravis. So essentially, when we're dealing with a muscular dystrophy, we're talking about genetic disorders where you inherit a mutated dystrophin. And dystrophin is a protein found inside of your cells, and it's an interfacing protein. So that means it really helps to form a linkage between the cytoskeletal proteins within the cell and the transmembrane proteins found in the plasma membrane. So when you inherit muscular dystrophy, you're inheriting a disorder where your actual scaffolding proteins are not working very well. Okay. Now, um, in terms of Duchenne's is the most common and most severe form of muscular dystrophy. Like there's cardiac muscular dystrophy, but it's a lot less common and much more rare. Duchenne's muscular dystrophy is inherited as an X-linked recessive disease, which means that when you inherit one X as a recessive X from your mother, you would have to inherit a good X from your father, because if you inherit a Y, there is no saving your bad X, and you end up with Duchenne's muscular dystrophy. So what ends up happening is you inherit like a recessive X from your mom and the Y from your father. You become a candidate for Duchenne's muscular dystrophy, and then your muscle cells are deficient in dystrophin. And as a result of that, the scaffolding of the sarcomeres to holding on to the plasma membrane falls apart. And then the muscle fiber falls apart, which means the muscle tissue will fall apart, which means the muscle essentially will die. And then when the muscle itself dies, right, it begins to atrophy away. So muscle weakness is actually present in these patients from fetal life onward, right? Because they inherit this disease the moment they're created as an embryo, right? They don't know what triggers it. They just know that there's a lot of inflammatory cells causing a lot of scarring and a lot of loss of muscle tissue. And as the disease progresses, like with all muscular dystrophies, the muscle tissue is replaced by fat and a loss of connective tissue. So, you know, a lot of times when you see diseases where patients muscle atrophy away, it kind of looks like they have gimpy arms and legs. But in Duchenne's muscular dystrophy, it's because it's replaced by connective tissue and it's replaced by fat. It looks like they've got these big old calves, but it's not actually a gastrocnemius muscle. It's actually just fat replacing where the muscle used to be. And because a lot of connective tissue is replaced by where the muscle used to be, these patients are at risk for becoming very obese because they're immobile, right? So that's one thing to think about. So in the treatment of these patients, they tend to put them on a very low calorie diet because they become immobile very early in life. You know, initially it affects the legs, the pelvis, the shoulders. They have kind of like a waddling gait, difficulty climbing stairs. They fall down easily. And then as, you know, the disease progresses, it kind of moves from the lower extremities or the extremities in general, heading towards the thoracic muscles, including the respiratory muscles. And then the patients usually die from respiratory failure. Once they're about 10, 12 years old, they're usually confined to a wheelchair. They're very immobile by that point. I actually know someone who his wife was carrying the recessive gene for Duchenne's muscular dystrophy, and they went ahead and did IVF and chose embryos and eggs that would lead to them having a girl, for one, to make sure that there was no muscular dystrophy for that baby, and also to selectively choose the embryo so that they would have a baby that doesn't have a chance of having Duchenne's muscular dystrophy. So, you know, there are things out there that you can do. So in terms of the treatment, like I said to you guys before, I mean, there's nothing really much. I know science is amazing, right, Ryan? When you use it for good, not when you use it for bad, but when you use it for good, it's like freaking amazing. But so yeah, like I was telling my class earlier, you know, you always think about things like when you're gonna have a baby with someone, you're like, oh, I'll make sure he's cute or she's cute so that, you know, my baby look good. but then you don't ever think of things like, you know what, maybe we should have a conversation about your family history and the genetic disorders that you may carry, because you and I having this baby together, if you were both carrying recessive genes, it's not gonna come out good for the baby, you know, and making a decision like that. So it's always something to think about. But, you know, then there's science. Anyway, so in terms of treatment, you know, you want to educate the family. You know, you could give corticosteroid therapy, but at the end of the day, I mean, the mobility of the patient is going to continue to decrease, and the heart muscles, the GI muscles, they become fibrotic, and the life of the child is just not optimal at all. And then they're going to die from respiratory failure. The treatment is not stopping the progression of the disease. It's just supportive care more than anything else. Yes, the dystrophin is not synthesized or if it's synthesized, it's not synthesized properly, and you're not able to make a proper dystrophin then. And then it's no good. Yeah. And then, what ends up happening is, let me see if I can go back to that slide. Yeah. So pretty much what ends up happening with these patients is the cells become very permeable, and muscle enzymes like creatine kinase leak out, and it causes for basically a lot of proteases and inflammatory processes to be activated, and it causes for death or necrosis of the cell. And then once the cell is necrosed and dies, it's replaced by connective tissue. There is no way to provide it with a functional dystrophin. The science is not that good yet, Ryan. No. Don't we wish? I wish we could just heal the world and make it a better place, We're trying, but we're just not there yet. Yeah. All right. So that leaves us with myasthenia gravis. All right. So myasthenia gravis is an autoimmune disease that's chronic. It causes sporadic, however progressive, abnormal fatigue of your skeletal muscles. Why does it do that? Okay. So if you guys remember, you've got an axon terminal that releases acetylcholine, and you have a muscle cell membrane for acetylcholine to bind to. What ends up happening is you have these autoantibodies that come and they block the receptor. So when acetylcholine tries to bind, it can't bind, and then the action potential can't occur, and the muscle does not contract. So all the muscles end up being very weak. Okay, so you get this muscle weakness, and the patients tend to be very, very fatigued, especially because of the muscle fatigue that occurs. So they don't know what causes it. They do know it's autoimmune, and you just have ineffective acetylcholine release, and the muscle fiber itself is just not responsive to acetylcholine because of these autoantibodies blocking it. So the fact that you can't have a nerve impulse at the neuromuscular junction causes for impairment of the muscle to work, right? And you need to have depolarization. You need to have the action potential. How else is the muscle going to contract? Okay. So with these patients, you tend to see muscles that are affected by the cranial nerves a lot, the face, the lips, the neck, the tongue, the throat, but it can affect any muscle group. And, the eyelids may droop, or the eyelids will close, or the skeletal muscles will become very weak, and they go through periods of exacerbation and remission. And especially because it affects women more than men, like most autoimmune diseases, in a woman's monthly cycle, there's a lot of biological stress, which causes exacerbations. So their disease can progress, during the monthly cycle. And another thing is that if it affects the skeletal muscle, they'll basically suffocate, right? Or they'll wake up in the middle of the night with, apnea and periods of suffocation. So that's life-threatening, obviously. There's no known cure for it, but what is the problem? The problem is that the acetylcholine can't bind to the receptor, right? Because the receptor is being blocked by these autoantibodies. So if you're looking to treat the disease, what you're going to want to do is you're going to want to flood the cleft with acetylcholine. So acetylcholinesterase is the enzyme that usually gets rid of excess acetylcholine. You want to inhibit that enzyme so you can have as much acetylcholine possible in the cleft to run to the receptors and bind to them before the autoantibodies come and block them out. So because of the autoresponsive negatives, the muscle end up being, then well, it's more, they don't normally become necrotic, but they will atrophy away from lack of use. Yeah, exactly. So the thought process is correct, Dan. Like, you just have insufficient stimulation, the muscles become very weak and fatigued, and they'll atrophy over time. Yeah. And then, to decrease the inflammation, corticosteroids are helpful. You could do plasmapheresis to clean up the autoantibodies out the blood. And then, of course, you want to suppress the immune system, right? Because it's the ones that's the problem. Their immune system is like attacking you. So, most patients live relatively normal lives unless they're going through an exacerbation. And of course, if it involves the respiratory system, that exacerbation can be life-threatening. So the immunoglobulin, Ryan, they usually give it during exacerbations to help to actually suppress the immune system. So the immunoglobulin G is what they'll give them, and it helps to suppress the immune system. Yeah. Yep. Any other questions, guys? Yes, Leandra, what's up?
So the necrosis of the muscle happens due to the fact that it's not being used.
They don't normally have necrosis. It's just weak muscles that will atrophy.
Gotcha.
Yeah. And it's because it's not being used. Yeah. No problem. Anything else, guys? Okay. Well, normally class is not ended so quickly, but we've been really moving through this unit. So guess what? Class is done. That is all I have for y'all today. So take the time to enjoy yourself. Remember, on Wednesday, there will be no live lecture. Absolutely, Miss Shannon. No live lecture on Wednesday, right? I have to attend the conference. I know that was quick, right? There will be a quiz, right? So you guys have lots of online assignments to do this week to keep yourself busy, even though I won't be here for you to hear my voice. And then next Monday, we'll do chapter 52. Exactly. Perfect. No problem, guys. All right. Well, you all take care, and I will see you next week, Monday. Remember, no class Wednesday. All right. Make sure you do all your work, though. All right, guys. Talk soon. Take care. You have a great day, too.